Welcome back, everyone. This is Mike. We continue our discussion on management of diabetes in pregnancy, a clinical update. Today's topic is the management of pregestational diabetes in pregnancy. First, how do we manage pre-existing type 1 and type 2 diabetes in pregnancy? First, let's talk about insulin use. Insulin is the preferred agent for management of diabetes in pregnancy because of the lack of long-term safety data for non-insulin agent. The physiology of pregnancy necessitates frequent titration of insulin to match changing requirements and underscores the importance of daily and frequent self-monitoring of blood glucose. Early in the first trimester, there is an increase in insulin requirements, followed by a decrease in weeks 9 through 16. Women, particularly those with type 1 diabetes, may experience increased hypoglycemia. After 16 weeks, rapidly increasing insulin resistance requires weekly increases in insulin dose of about 5% per week to achieve glycemic targets. There is roughly a doubling of insulin requirements by the late third trimester. In general, a smaller proportion of the total daily dose should be given as basal insulin, less than 50%, and a greater portion, greater than 50%, as prandial insulin. Now, late in the third trimester, there is often a leveling off or a small decrease in insulin requirements. Due to the complexity of insulin management in pregnancy, referral to a specialized center offering team-based care with team members including maternal fetal medicine specialists, endocrinologists, or other provider experienced in managing pregnancy in women with pre-existing diabetes, dietitian, nurse, and social worker, as needed, is recommended if this resource is available. None of the currently available human insulin preparations have been demonstrated to cross the placenta. All insulins are pregnancy category B except for glargine and lulicin, which are labeled C. The recent Cochrane systematic review was not able to recommend any specific insulin regimen over another for the treatment of diabetes in pregnancy. Now, diabetes in pregnancy is associated with an increased risk of preeclampsia. Based upon the result of clinical trials, the U.S. Preventive Services Task Force recommends the use of low-dose aspirin, around 81 milligrams per day, as a preventive medication after 12 weeks of gestation in women who are at high risk for preeclampsia. A cost-benefit analysis has concluded that this approach would reduce morbidity, save lives, and lower healthcare costs. How do we manage pregnant women with type 1 diabetes? Women with type 1 diabetes have an increased risk of hypoglycemia in the first trimester and, like all women, have altered counter-regulatory response in pregnancy that may decrease hypoglycemia awareness. Frequent hypoglycemia can be associated with intrauterine growth restriction. In addition, rapid implementation of tight glycemic control in the setting of retinopathy is associated with worsening retinopathy. Education for patients and family members about the prevention, recognition, and treatment of hypoglycemia is important before, during, and after pregnancy to help to prevent and manage the risk of hypoglycemia. Insulin resistance drops rapidly with delivery of the placenta. Women become very insulin sensitive immediately following delivery and may initially require much less insulin than in the prepartum period. Now, pregnancy is a ketogenic state, and women with type 1 diabetes, and to a lesser extent those with type 2 diabetes, are at risk for diabetic ketoacidosis at lower blood glucose level than in the non-pregnant state. Women with pre-existing diabetes, especially type 1 diabetes, need ketone strips at home and education on diabetic ketoacidosis prevention and detection. The role of continuous glucose monitoring in pregnancies impacted by diabetes is still being studied. In one random clinical trial, continuous glucose monitoring used in pregnancies complicated by type 1 diabetes showed improved neonatal outcomes and a slight reduction in A1C, but no differences in several hypoglycemic events compared with control subjects. Next, how do you manage pregnant women with type 2 diabetes? Type 2 diabetes is often associated with obesity. Recommended weight gain during pregnancy for overweight women is 15 to 25 pounds, and for obese women is 10 to 20 pounds. Glycemic control is often easier to achieve in women with type 2 diabetes than in those with type 1 diabetes but can require much higher doses of insulin, sometimes necessitating concentrated insulin formulations. As in type 1 diabetes, insulin requirements drop dramatically after delivery. The risks for associated hypertension and other comorbidities may be as high or higher than with type 2 diabetes as with type 1 diabetes, even if diabetes is better controlled and of shorter apparent duration, with pregnancy loss appearing to be more prevalent in the third trimester in women with type 2 diabetes compared with the first trimester in women with type 1 diabetes. Let's discuss pregnancy and antihypertensive drug considerations. In normal pregnancy, blood pressure is lower than in the non-pregnant state. In a pregnancy complicated by diabetes and chronic hypertension, target goals for systolic blood pressure 120 to 160 millimeters mercury and diastolic blood pressure of 80 to 105 millimeters mercury are reasonable. Lower blood pressure levels may be associated with impaired fetal growth. In a 2015 study targeting diastolic blood pressure of 100 millimeters mercury versus 85 millimeters mercury in pregnant women, only 6% of whom had GDM at enrollment, there was no difference in pregnancy loss, neonatal care, or other neonatal outcomes, although women in the less intensive treatment group had a higher rate of uncontrolled hypertension. There are few randomized controlled trials of antihypertensive therapy in pregnant women with diabetes. A 2014 Cochrane systematic review of antihypertensive therapy for mild to moderate chronic hypertension that included 49 trials and over 4,700 women did not find any conclusive evidence for or against blood pressure treatment to reduce the risk of preeclampsia for the mother or effects on perinatal outcomes such as preterm birth, small for gestational age infants, or fetal death. The more recent Control of Hypertension in Pregnancy study, or CHIPS, enrolled mostly women with chronic hypertension. In CHIPS, targeting a diastolic blood pressure of 85 millimeters mercury during pregnancy was associated with reduced likelihood of developing accelerated maternal hypertension and no demonstrable adverse outcome for infants compared with targeting a higher diastolic blood pressure. The mean systolic blood pressure achieved in the more intensely treated group was 133.1 plus minus 0.5 millimeters mercury, and the mean diastolic blood pressure achieved in that group was 85.3 plus minus 0.3 millimeters mercury. A similar approach is supported by the International Society for the Study of Hypertension in Pregnancy, which specifically recommend use of antihypertensive therapy to maintain systolic blood pressure between 110 and 140 millimeters mercury, and diastolic blood pressure between 80 and 85 millimeters mercury. Current evidence supports controlling blood pressure 110 to 135 over 85 millimeters mercury to reduce the risk of accelerated maternal hypertension, but also to minimize impairment of fetal growth. Now, during pregnancy, treatment with ACE inhibitors and angiotensin receptor blockers is contraindicated because they may cause fetal renal dysplasia, oligohydramnios, and intrauterine growth restriction. Antihypertensive drugs known to be effective and safe in pregnancy include methyldopa, nifedipine, labetalol, diltiazem, clonidine, and prazosin. Atenolol is not recommended. Now, chronic diuretic use during pregnancy is not recommended as it has been associated with restricted maternal plasma volume, which may reduce utero-placental perfusion. On the basis of available evidence, statins should also be avoided in pregnancy. The American College of Obstetric and Gynecologists also recommend that postpartum patients with gestational hypertension, preeclampsia, and superimposed preeclampsia have their blood pressure observed for 72 hours in the hospital and for 7 to 10 days postpartum. Long-term follow-up is recommended for those women as they have increased lifetime cardiovascular risk. Here are the recommendations for management of pregestational diabetes in pregnancy. First, insulin is the preferred agent for management of both type 1 diabetes and type 2 diabetes in pregnancy because it does not cross the placenta and because oral agents are generally insufficient to overcome the insulin resistance in type 2 diabetes and are ineffective in type 1 diabetes. 2. Women with type 1 or type 2 diabetes should be prescribed low-dose aspirin 60 to 150 milligrams per day, usual dose of 81 milligrams per day, from the end of the first trimester until the baby is born in order to lower the risk of preeclampsia. 3. In pregnant patients with diabetes and chronic hypertension, blood pressure targets of 120 to 160 over 80 to 105 are generally suggested in the interest of optimizing long-term maternal health and minimizing impaired fetal growth. And lastly, potentially teratogenic medications, for example, ACE inhibitors, angiotensin receptor blockers, and statins, should be avoided in sexually active women of childbearing age who are not using reliable contraception. This ends our discussion on management of pregestational diabetes in pregnancy. See you next time when we discuss postpartum care.